Like
Dr. Nirav, you can switch on the video now. We'll start the meeting. Yes. So good morning, all friends. Welcome back to Saturday Club morning meeting. And today we have a very interesting topic, and that is managing dyslipidemia, what the Indian guidelines say. We have been talking about dyslipidemia very often here on this platform also. But there are a lot of controversies associated, and it's good to hear what the Indian scenario is all about. And for that, we have Dr. Nirav Balani, a very eminent interventional cardiologist of Vadodara. He has done his MD, DNB, and FSC, CAI. His areas of interest are complex coronary interventions like bifurcation lesions, CTOs, image-guided PCI, etc. He's advisor to Indian School of Business, Hyderabad, for the course of Doctor Entrepreneurship, and director of Rhythm Group of Hospitals at various places like Vadodara, Dahod, Banswara, Bhavnagar, Bharuch, and Sambalpur, Odisha. So welcome, Dr. Nirav, to Saturday Club of Baroda meeting. And you have about 40-45 minutes to talk, and we'll have about 10-15 minutes of interaction. So over to you, Dr. Nirav.
Thank you, Satish sir, and it's an honor. It's an honor to be a part of this esteemed meeting. As I understand, this is the longest lasting academic, and that is a that is an achievement in itself. It is more than almost, as I understand, more than almost 40-50 years since this is regularly going on. So it's an honor to be on this platform. We have a lot of learned colleagues here from varied strata. So I chose a topic which was common to all and not focusing on intervention. As we all know that the ASCVD risk is increasing and by leaps and bounds in India. In the Western countries, the data is showing that now they are stabilizing and in fact decreasing in the risk of ASCVD. But India, the curve is on the upstroke, and the cases of ASCVD are increases. What is more alarming is that more and more younger population. In India, the coronary artery disease occur almost a decade earlier compared to our Western parts. Unfortunately, we do not have any of our own Indian guidelines. We always rely upon the ACC-AHA guideline, the European Society guidelines, and the UK NICE guidelines for many of our treatment modalities targeting diabetes, targeting dyslipidemia, and targeting hypertension. And therefore, a group of esteemed cardiologists from India in 2016 got together and formed the Lipid Association of India, which I think many of us would be knowing. So I'll be sharing slides from their association, and we can debate what is the Indian scenario. I'll start my screen share. So as I said that this was started as an expert consensus statement in 2016. That was the part 1. And in 2020, they released the part 3. So this was the beginning of the idea that we as Indians are different genetically and phenotypically. We are different from the Western world, and we need to have our own guidelines rather than blindly following the European and the American guidelines. So again, as we discussed, there is a tsunami of premature heart disease in Indians. The average age of MI, like 25% of MI is in the people aged less than 50 years of age, and close to 50% of deaths are also less than 45 to 50 years of age. So we can clearly see that there is a rise in the number of Indians with coronary artery disease in the less than 30 years of age from 8 to 10%, and the number of CAD deaths in less than 30 from 14%. This is not the scenario in the developed countries. So if you see the US age standardized death rates attributable to CVD, they are much less compared to the Indian scenario. And as we all know that the mortality rates because of coronary heart disease is declining in majority of the developing countries, but on the other side, in India particularly, it is on the upstroke of the graph. So this is how the prevalence of CAD is rising in India. Year on year, we are getting more and more CAD patients. WHO estimated, and I think that has been proven true, that by 2020, more than 50% of cardiac patients worldwide will be Indians, and India is becoming the heart disease capital of the world. Sorry. Again, if we see that the dyslipidemia of the Indian subcontinent is different from the Western counterpart. Most of the Western counterparts have high LDL-C levels. However, our dyslipidemia, as it was studied by the ICMR in 2014, our dyslipidemia has more of low HDL-C and high triglyceride compared to normal or a little bit high of total cholesterol and LDL-C. So there is a contrast, and we know that high triglyceridemia with low HDL-C is highly atherogenic. So again, if we follow the guidelines based on HDL-C, we may be missing out on something which our population specifically has, and that is low HDL-C. Our population, as we know in our clinical practice, as low HDL-C, defined as HDL-C less than 40 milligram per deciliter in men and less than 50 milligram per deciliter in women. So this is very peculiar to the Indian subset. Our dyslipidemia is not the same as that of the European or the Americans. So the expert recommendation is needed, as we already discussed, that compared to other ethnic groups, Southeast Asians have higher prevalence of atherogenic dyslipidemia, meaning high triglycerides, low HDL, and near normal or a little bit high of LDL-C and total cholesterol. The higher prevalence of traditional risk factors and greater prevalence of risk factors at a younger age. Lack of awareness. We as a society have lack of awareness for CAD prevention, dietary factors, and physical inactivity. Physical inactivity because of rapid urbanization. So these are the reasons, and therefore, so these are the comparison of the major guidelines, the ACC, ADA, ESC, and the Indian International Atherosclerotic Society. We'll not go into the details of this, but what I want to show is this. So the National Lipid Association recommendation that initiate the therapy based on risk and lipid levels and treat to specific goals. So the category that normally we classify as low risk, moderate risk, and high risk. But the Indian Association is also focused on a very high risk situation wherein there is an established ASCVD risk and diabetes with 2 or more risk factors and or end organ damage. So any patient who is whose age is less than 40, less than 15, female, and has an established ASCVD falls in this very high risk group. And there, the Lipid Association of India has further decreased the target of LDLC, which we will see in the. Also, what Indian Association guidelines says is that rather than focusing only on LDLC, the non-HDLC cholesterol should be used in preference to LDLC as the treatment goal for lipid lowering therapy. So right now, majority of the guidelines say that non-HDLC is to be used as a co-primary target. Your first target should be to decrease the LDL levels below 100 and below 70 in very high risk patients. But non-HDLC is also an important target, and that because our patients are different, we should target non-HDLC equally importantly. And that was Joint British Society consensus recommends this. So what do the Indian expert feels? With this background, let us understand what that the Indian experts feel. So 8 meetings occurred in the period of 2016 to 2019 in 6 metro cities, and the Lipid Association of India brainstorming the meets. And regional experts from 18 states and 30 cities, 18 states and 30 cities got together. Around 153 experts across India got together to develop this consensus statements. And what was the method used? The method used was that each meeting was conducted using a standardized format. The key issues related to dyslipidemia management in Indians were first presented in the form of lectures, followed by a discussion. And the discussions were based on existing data on the epidemiology and randomized controlled trials. At the end of each discussion, a standardized questionnaire was given to all the participating experts to record their opinion on various aspects of dyslipidemia management in Indians. And these questionnaires were also sent to experts who could not attend the meeting in person. So basically, it was a cohort of senior physicians, senior cardiologists practicing dyslipidemia in Indian patients since long, and an expert consensus, their views were recorded. The information collected was then summarized, and the key findings were further discussed amongst the members of the core expert group before preparation of the final draft. So now what are the recommendations? So this recommendation has come into 3 parts. The first part was in 2016, then in 2018, and now in 2020, we have the third part. So first part is universal screening of all Indians. We are a country where young cardiac deaths is common. Premature CAD is very common, and therefore by the age of 20 years or at the time of college admission or at the earliest opportunity when you get in connect with a adult male or female, you should advise them lipid profile for the purpose of early detection of high risk individual. So this is a recommendation which we know that it is very difficult to follow because as a country we are bit negligent about our health. But yes, between the age of 20 to 40, you should have one lipid profile done for all of our patients. That is the universal screening of all Indians. Second is, if you find dyslipidemia in the lipid profile, you should rule out secondary causes of dyslipidemia like hyperthyroidism, uncontrolled diabetes, obesity. One more important point that the guidelines, the consensus statement, it's not a guideline, mind you, it's a consensus statement. One more important point they say is that fasting lipid is not mandatory because non-HDLC, the focus is on non-HDLC. So non-HDLC is calculated by total cholesterol minus the HDL cholesterol. We all know that the triglyceride portion of the lipid profile is affected by the fasting status. The other elements like the HDL, the LDL, the total cholesterol is not affected by the fasting sample, and therefore it is not mandatory to do a fasting sample in all the patients. You may do a non-fasting sample, and non-HDL should be calculated in every subject. So here you see the difference between the routine guidelines, the European American guidelines. Here because the Indian dyslipidemia is different and we have more of low HDLC, non-HDLC should be calculated in every subject. Identify the patient based on the risk category, based on conventional and non-conventional risk factor. So here it is more or less same as per the guidelines. So how do you identify the risk? So the risk factors being age, in the males it is more than 45 and females more than 55 years of age. Then history of premature, family history of premature CAD. Now what is defined as premature CAD? So the family history of premature CAD is defined as if any family, any first degree family male member less than 55 years of age has suffered a cardiac event, or a first degree female relative has suffered a cardiac event age less than 65 years. Then current tobacco chewing or cigarette smoking, high blood pressure defined as pressures more than 140 by 90 millimeters of mercury or on blood pressure medication, and low HDLC. Again, I would like to emphasize that we are a population where the HDLC is very low. So no low HDLC defined as in males less than 40 milligram per deciliter and in females more than 50 milligram of deciliter. So these are the major risk factors for ASCVD. Now, what are the non-conventional risk factors? The non-conventional risk factors are calcium score. The calcium score, coronary artery calcium score of more than 100, carotid intima media thickness. It can be easily done by a carotid Doppler, carotid intima media thickness. The presence of atherosclerotic plaque, aortic pulse wave Doppler, again can be documented by an echocardiography. HSCRP. Now the world is focusing on HSCRP. Why? Because majority of the trials, many of the trials, not majority, sorry, many of the trials have shown that even when you control the HDLC, still 25% of people go on to have cardiac events with a HDLC of 70 also or below. 25% of people over the next 5 years may develop cardiac events. So the inflammatory process is still on, and then HSCRP more than 2 is identified as a risk factor. So this is a non-conventional risk factor which we should focus upon. And the newer one, because we are a country with premature CAD, lipo-small a. Lipo-small a is a marker of premature CAD. Lipo-small a more than 50 milligram per deciliter indicates high risk for development of premature CAD. So these are the non-conventional risk factors which easily can be ordered from our OPD practice. Coronary artery calcium score, carotid intima thickness, atherosclerotic plaque on carotid Doppler, aortic pulse wave velocity, HSCRP and lipo-A. So now what is the recommended approach to ASCVD risk stratification in India? So first of all, what you should classify is, depending on the major and the minor non-conventional risk factor, is whether the patient is very high risk, intermediate risk, or low risk. Once you have identified into this group, let us say, for example, a patient falls into low risk by the major ASCVD risk factor calculator. But if the patient in the low risk strata also has more than one moderate risk non-conventional risk factor in the form, let us say that he has only one major ASCVD risk factor and is in the low risk category, but his calcium score is 400, then you should push him to the above category to moderate risk. So that is what the consensus statement says, that low risk with one moderate non-conventional risk factor like calcium score or carotid intima thickness or lipo-A more than 50, you should shift to moderate. Moderate with more than one non-conventional risk factor, shift to high risk. So non-conventional risk factors also should be assessed at the time of starting the therapy. Again, we can highlight the ASCVD risk factors. So major risk factors would be age more than 45 and age more than 55 in females, family history of premature CVD, current smoking, pressures more than 140/90 or on BP medicines, and low HDLC. So these are, if we have two or three or more ASCVD risk factors, then it forms a high risk category. The other risk factors, as we discussed, were coronary calcium of more than 300, carotid intima thickness, lipo-A more than 50. And once you have classified the patient into low, moderate, high, or very high risk, you have to start therapy. Now, one concept is, because India has a high chance of premature CAD, the concept in the European and the American countries is to estimate a 10-year risk. But what the Indian Association says is, estimate the lifetime risk, not 10-year. Why do you want to identify a 10-year risk? Estimate the lifetime ASCVD risk in all low risk individuals. And that is, so this slide is very important. It says that the 10-year risk versus lifetime risk. So calculate the lifetime risk assessment rather than 10-year risk. Why? Because higher prevalence of CAD in the younger Indian population, short-term risk does not become high until later in life, and thereby we lose the opportunity for a timely prevention of CAD. The goal of primary prevention is to reduce the lifetime CV risk and not for just 5 years or 10-year risk. And there are a lot of lifetime risk calculators available. But what the consensus recommend is the JSB. So these are the few calculators: ACC pooled cohort, JBS3 calculator, Lloyd-Jones-Framingham risk algorithm. They are easily available on internet and they can be calculated. The consensus feels that because the British Society cohort had a lot of South Asian people and they represent our community, they had a lot of Indians in the cohort. So the JSB3 risk calculator is found to be the most comprehensive in Indian population, and this is how it looks. The JBS3 calculator, it can be easily seen on internet. There are certain parameters which you have to add. For example, the age, whether you smoke or not, what is your HDL cholesterol and what is your total cholesterol, what is your BMI, and what is whether you have suffered from a past cardiac event or not. So after answering a couple of questions, you get a lot of data. And most important two data that I normally follow is the heart age. For example, someone may say, what is your age? I would say I'm 44. Someone may say I'm 34, and someone may say I'm 54. But it may happen that if someone who is 50 years of age, 5 years elder than me, but is regularly exercising, his heart age may be younger than my age. So the concept of heart age was introduced by our seniors who formed the Lipid Association of India. So heart age, healthy years. It also gives you in a thermometer like a graph. If you can see the third thing, I don't know whether my pointer is seen. So this is the health years. It is like a thermometer picture which shows you how you're healthy and what are the chances of you developing any cardiac event in the next 5, 10, 20 years. And then a lot of other bar graphs can be extrapolated from this JBS3 calculator. So I would request you to start using the JBS3 calculator. You may do it for a couple of patients initially. It is a very easy tool, and this is really eye-opening. This really, even your patients would be convinced when you show that your age is 44, but your heart age is 54. So you should now start thinking about your heart. Then the treatment goals. Treatment goals are more or less standardized. However, two changes that the Indian Association has done is for very high risk, they have pushed the treatment goal to LDL-C less than 50, which the European guidelines say it is 55. Nothing much of a difference there. So treatment goals. If the patient is very high risk, you should target a LDL-C of 50, less than 50, and non-HDL-C of 30. So here the thumb rule would be you should target a non-HDL-C of 30 more than the LDL-C. If you see across the all the categories, it is 30 more. So this is 50, 80, 70, 100, 100, 130, 100, 130. So the target should be a LDL-C of 50 in very high risk, 70 in high risk, and in moderate and low risk less than 100. Corresponding to this, the non-HDL should be 30 more. So it would be 80, 100, 130, and 130. So this should be your target depending on the category the patient is. Now, how do you get this target? Also one more is concept of primordial prevention. Now, what is primordial prevention is? Now, we all know primary and secondary prevention. Primordial prevention is prevention of risk factors causative to the disease, and thereby the reducing the risk likelihood of development of disease should start from early childhood. A data shows that, I will show it in the subsequent slides. A data shows that in 12 students of 12th standard in Delhi, more than 50% were obese and dyslipidemic. The Indian class students in 12th standard, more than 50% were obese and dyslipidemic. So what are the roles of therapeutic lifestyle changes? Lifestyle changes are an integral part of prevention and treatment of dyslipidemia. So choose an appropriate diet. Calorie reduction is the key to weight loss and dyslipidemia treatment. Smoking should be stopped. Alcohol should be avoided. Physical activity, moderate intense physical activity is recommended for every day, minimum 5 out of the 7 days in a week. And the role of yoga and stress management was also emphasized. I'll not go into the detail of this. The targets of HDLC therapy, as we have already seen, it should be less than 50 milligram per deciliter, and it is safe. Statins are the primary modality for reducing LDL-C, except in high risk and very high risk group. Start with moderate intensity statin and titrate up to the tolerated dose to achieve the goal. Discuss the risk and benefit of treatment with the patients. Lipid profile should be checked at the time of diagnosis and then every 3 to 6 months on treatment. Every 6 months is what I follow on treatment. When maximally tolerated statin and we are not able to get the goal, we should add on therapy, and add on therapy would be ezetimibe, PCSK9 and bempedoic acid. So targets of non-HDLC would be non-HDLC is total cholesterol minus HDLC. A non-fasting sample is okay for this. It includes all atherogenic particles like VLDL, VLDL remnants, chylomicron remnant, and LDLC and liposmall a. So the measurement of non-HDLC does not require fasting sample, and expert considered it to be a co-primary target for therapy. Statins are effective agents for decreasing the levels of non-HDLC, even if the LDLC is at goal. So the goal for non-HDLC is 30 milligram more than that of LDLC that we already discussed. Triglycerides. Majority of the European and American guidelines do not focus on triglycerides, but we as an Indian population have hypertriglyceridemia and low HDL, which is more common, and therefore elevated triglyceride level should be treated. The patient should be evaluated for possible secondary causes of hypertriglyceridemia like uncontrolled diabetes, thyroid, and the goal of TG should be less than 150 and preferably less than 100. The first step to reduce triglyceride would be lifestyle modification. Lifestyle modification alone, for example, walking at least 30 to 35 minutes a day for minimum 5 out of the 7 days in a week. Walking, cycling, jogging, swimming, whatever, a cardiac exercise can help to reduce the TG levels by 50%. Only exercise. Achieving non-HDLC goal will correct hypertriglyceridemia automatically. And then even after doing all this, your TG levels are more than 500, then fibrate should be used. Fibrate should be used for TG levels more than 500. Otherwise, statin therapy alone will reduce, lifestyle modification and statin therapy alone will reduce the triglyceride in majority of the cases. For HDLC, we know that there is no drug which increases the HDLC. So HDLC does not appear to improve the overall cardiovascular outcome. The current evidence does not support the use of niacin to increase the HDLC. Physiologic measures that include exercise may help in increasing HDLC. Statins and diabetes. Again, we know that along with the coronary artery, diabetes is a major risk factor, and we are the diabetes capital of the world. And so although the statins are associated with the increased risk in the statins, we know that can increase the risk of new onset diabetes, but it is significantly outweighed by the benefits, and the risk is greater with intensive therapy in patients already predisposed to develop diabetes. So the advantage is much more than the risk, and therefore statin should be prescribed in the patients with diabetes. Patients with risk factor for diabetes mellitus should be screened with fasting glucose or HbA1c ideally prior to starting therapy, and then after it should be monitored within 1 year of initiation at intervals no longer than 3 years. So HbA1c should be done in patients who are on high dose statin therapy at least a yearly interval. Aggressive lifestyle management is very important in preventing development of diabetes in patients receiving statin therapy. So yes, statins can cause diabetes, but the advantage is much higher. So you should not restrain from prescribing statin in diabetic patients, and you should keep a watch on FBS and HbA1c yearly when the patient is on high intensity statin. Statin intolerance, let us not go into the detail of this. It is not that very common. Statin related neurotoxicity and hepatotoxicity, again not very common, but let us talk about hepatotoxicity. In an asymptomatic rise in hepatic enzyme is common, but the incidence of more than 3 times, for example, if you say that the SGPT normal value is 50 milligram, if it does not go beyond 150, there is no reason to stop statin, and it is very rare. It occurs in less than 3% of the population. Also in patients of non-alcoholic steatohepatitis and NASH, statin treatment is safe and it may lead to the resolution of NASH. So do not be afraid of hepatotoxicity of the statin. It is there, but it is in very few patients, and in those patients only it needs to be stopped. Borderline elevation of SGPT or SGOT does not warrant stopping of statin therapy. So primary prevention, statin, calculate the lifetime risk score in age group of 20 to 50 years in absence of any CAD. Start therapy in patients with high or moderately high lifetime risk and low use of low dose statin like 5 mg rosuvastatin or 10 mg atorvastatin. This is for the younger population for primary prevention. So the recommendation would be, these recommendations in the statement are not mandatory to the medical community and they are the opinions. So as I said, this is a consensus statement. There are no Indian guidelines. These are the opinions of lipid experts from our country. The clinician should use his own judgment and experience to tailor the therapy for each patient. A detailed discussion with the patient prior to starting any medication for dyslipidemia is essential. So what are the consensus summary? Early screening at the age of 20 years or between the 20 to 40 years, when you get the first chance to meet him, or at the time of college admission, you should get one lipid profile. Exclude the secondary causes of dyslipidemia. Use the Lipid Association of India algorithm, as we already have seen, for ASCVD risk assessment. It does not need calculators and there is no class of recommendation or level of evidence as we know with guidelines. Use a risk calculator, and preferably the risk calculator should be JBS3 to assess the lifetime risk score, especially in the group of 20 to 50 years of age. Stratify the patients into various risk categories like low risk, moderate risk, high risk, and very high risk categories. LDL-C is the primary target and its monitoring is important during treatment. LDL-C levels of less than 50 milligram per deciliter is safe. Non-HDL-C, new concept. Non-HDL-C is the next target and is equally important for the Indian patients. Non-statin drugs are important in dyslipidemia management, but there is no role of niacin. Role of omega-3 fatty acid is also debatable. The non-statin drugs which we advocate would be ezetimibe, bempedoic acid, and the newer PCSK9 inhibitors. Lifestyle modification is an integral and an important part in the management and prevention of dyslipidemia. We should stress on lifestyle modification, diet and exercise. Practice primordial prevention, and public awareness is essential to address this epidemic. We all know that these are the recommendations, but recommendations are nothing without implementation. So let us try and implement this, and let us see how we can make a difference to the Indian society and prevent premature CAD. Thank you.
Thank you, Dr. Nirav. That was very informative and very comprehensive guideline. So you can switch off the screen sharing. Yes, we can have more discussion. Now the house is open for comments, questions, discussion. We have a good amount of time. 15-20
Nirav, yes. Can you throw some more light on statin-induced diabetes?
See, statin in high, particularly when you're using it in a high intensity dose, that is 80 milligram of atorvastatin and 40 milligram of rosuvastatin. So this high intensity statin dosage may lead to development of diabetes. But again, you have to understand this is in only those patients who are high risk for developing diabetes, not in all patients. The incidence is close to 5%. For example, if someone is in the HbA1c range of 6 to 6.5 and high intensity statin is used, he may become a full-blown diabetes with an HbA1c of more than 7.5. But it is not in all. So as a cardiologist, I would always say that you should not stop treating patients just because we are worried that it may lead to new onset diabetes. At the same time, yes, we should always keep a watch, and annual, whenever a patient is on a high intensity statin therapy, Atorva 80 or Rosuva 40, annual fasting sample and an annual HbA1c should be done.
And it is a class effect or some specific statin? Rosuva
no, it is a class effect, but a high dose effect.
High dose.
There are some comments and questions from the chat box. Any indication for use of statins preventively if lipid profile is normal? Dr. Pradeep said. He has asked this question. Yeah. Dr. Nirav.
Yeah. So basically that is what we are focusing on. So that is where the lifetime risk, that is where the lifetime risk calculator comes. So for example, if my patient is a 35-year-old, for a routine screening, he does a lipid profile and the lipid profile is normal and it does not have any risk factor. So what has happened here is, conceptually, the patient came to us early, and therefore we will miss out. Because when if you see the major risk factors, it is age more than 45 in males and age more than 55 in females. So if the patient comes to me before 45 years of age, he will not have a major risk factor. But we should understand that 4 years, 5 years down the line, he may have one major risk factor, that is age more than 45. And therefore the JBS3 lifetime risk calculator would help in such patients. If these patients at the JBS3 lifetime risk calculator fall in the low risk category, does not have a significant family history, as we see the major risk factors, that is family history, age, smoking, tobacco use, pressure, and non-HDLC of less than 40 for males and less than 50 for female, we may not put him on statins, but definitely we will call him again when he's 45 years of age for a repeat risk assessment.
There is a question from Dr. Ganesh Kumar. He has commented, you said drugs like fenofibrate are not necessary till triglyceride level goes beyond 500. Only statins alone are sufficient in this situation. What is the harm in adding this fibrate to statin when TGL is just 350?
So there is absolutely no harm in adding, and it is a wonder drug. But what my problem is, if you see our practice, we have a combination of statin with fenofibrate available, which we normally prescribe whenever the triglycerides are high. But unfortunately, that combination has only 10 milligram of a statin and 160 milligram of fenofibrate. So what is happening is, we are under treating. As a practice, we don't give a prescription like 10 plus 160 milligram separately and 20 milligram rosuvastatin again, making it 30 or 40 milligram rosuvastatin. So we are under treating with the statin dose. So what the consensus statement says is that first you should maximize the upper tolerable low dose of statin, and if still you are not getting results, add other therapy. So my take home message here would be that less than 160 milligram of fenofibrate is a good drug. It does not have many side effects. It is triglyceride specific. So you should definitely give if it is your clinical practice. But at the same time, you should be utilizing a moderate dose of statin if the other parameters are such, and not a low dose, because 10 milligram atorvastatin, the combination that is available, is a low dose statin therapy.
Yes. Any other question, comment from the audience?
Nirav, Hemant Sant here. Can I ask?
Yes, sir.
Yes.
My question is, if atherosclerosis is so important and lipid profile, then how can you explain a single vulnerable plaque at a single location with rest of the arteries, all microcirculation normal in a non-hypertensive, non-diabetic person?
I did not get the first. I understood the question in the second half. How do you explain a single vulnerable plaque with everything normal in a patient with no risk factors, no hypertension, nothing? What was the first part?
If the lipid profile is so important, then the atherosclerosis should be in all vessels. And the persons dying suddenly are dying due to vulnerable plaque, your cardiologist say.
Yes, sir. Sir, lipid profile is a part of the spectrum. So that is why we have new molecules so that is what I told during my lecture also, that in trials who have focused on very high dose statin therapy for reducing the HDL-C levels to less than 70, still more than 25% patients develop cardiac events over the period of 4 to 5 years. And therefore now they are shifting their focus to other inflammatory markers like hsCRP, liposmall a. So this is a process which is basically has inflammation at its core. And then there are other factors also which may be responsible. You are right that we have seen patients who have no risk factor. For example, after COVID, I have seen a lot of young patients. I have seen a lot of young patients who have a single plaque rupture, thrombus, MI, and these patients sometimes just with thrombolytic may have clean artery again. They do not have blockages. They do not have atherosclerotic plaques. They just have a plaque rupture and development of thrombus. When you treat them with thrombolytics, you see the angiography after 6 to 12 hours, you have a clear artery, recanalized artery, and you don't need to push in a stent. So lot of different pathophysiology work. Lipid profile is a major part of it. But yeah, the trials also have shown their limitations, wherein we have clearly seen that more than 1/4 of the patient with a good lipid profile control can still develop cardiac events. And therefore, newer markers like lipo small a in particularly patients less than 50 years of age, ApoB is again very important. ApoB to 1 ratio, HSCRP. Initial days we used to have homocysteine. So these are other inflammatory markers which should be checked.
My question was actually slanted towards sleep apnea, respiratory physiology affecting the physics of coronary circulation, which causes a vulnerable plaque at a crucial juncture, which breaks suddenly. That
Sleep
was
apnea
my-
would be, sleep apnea is altogether another spectrum. Sleep apnea would lead to both coronary, cerebrovascular, renal dysfunctions. The commonest cardiac effect of sleep apnea is a diastolic heart failure. They have diastolic heart failure. The other thing could be, yes, definitely, as you said, coronary artery disease and stroke.
Okay. There is another question from Dr. Ganesh. Is regarding the dose of statin. Like he says that intense dose of statin, like atorvastatin 80 milligram is given subsequent to PTC or CABG for a recent event of coronary artery disease or stroke for the plaque stabilization role. How long should this intense dose be continued after PTCA? And when can we reduce the dose of to 20 milligram or 40 milligram? And subsequent to that, he has also asked, many of my patients complain of intense muscle pain with this high dose of statin. So your comments.
Yeah. So basically, once you start a patient, for any patient, why only CABG and PTCA? For any patient, when you start a statin therapy, you're already risk stratified. Now, because he has one ASCVD event, PTC or CABG, he falls into the high risk and very high risk strategy. And whenever the patient is on a high risk or a very high risk strategy category, sorry, they are started on high dose, as you rightly said, 40 milligram rosuvastatin or 80 milligram atorvastatin. Now, after that, you repeat your cholesterol at a 3 to 6 month interval. I normally do it at a 6 month interval. What is your target? If I can show you my slides again, what is your target? Your target should be HDL-C less than 70 in patients with high risk and less than 50 in patients with less than very high risk features. So if your patient is, let us say, in the high risk category, and with a 80 milligram statin, atorvastatin, at the end of 6 months, when you do a lipid profile and his cholesterol HDL-C levels is less than 70, then you can go down to 40 milligram or 20 milligram. But mind you, you cannot stop here. You cannot rest assured. The patient has to be advised that you have to continue on your lifestyle modification, diet, exercise, and continue a moderate intensity or a low intensity statin. Repeat your lipid profile at the end of 6 months again. If the HDL-C are above target, again, let us say you had brought it the HDL-C to 70, and now by reducing the dose, the patient again become complacent. He gains weight of 5 kg, stops exercising, and after the 6 months, LDL-C levels are now 100. Then you have to again switch over to the high dose therapy. So it is all targeted by what the doses are targeted by what is your target LDL-C levels.
Okay.
In some patients, if they are religious in their lifestyle modification, we can get them to 20 milligram and then annually we do a lipid profile. And if they are into, if the target is achieved, we do not increase the dose. So it is a jump in, jump out situation wherein every 6 months to 1 year, if the patient is not compliant with his lifestyle modification, the doses may vary. Coming to the intense muscle pain. So again, you know, what I have seen in my practice is, especially middle-aged females and elderly males have some sort of muscle ache because of other factors also. The commonest being vitamin B12, vitamin D deficiency, some amount of myalgia secondary to viral illnesses. So how do you link it with a statin induced myopathy? First of all, the incidence of statin-induced myopathy in various trials is only 1 to 3%. So if I treat 100 patients with statin, it will be there on only 1 or 2 patients. It is not very common, number one. Number two, if a patient complains of intense muscle pain with high dose of statin, what you should try to rule out is other causes of muscle pain. And still you are convinced, then what is definition of statin-induced myopathy? Statin-induced myopathy definition is if the patient cannot tolerate one statin in high dose, you should switch to other statin in moderate dose. And if he still cannot tolerate in other statin, for example, if you feel that rosuvastatin 40 milligram is not working for him and he is developing myopathy with that, switch it to atorvastatin 20 milligram or simvastatin 20 milligram or pravastatin, pitastatin, whatever you like, and still he is complaining, then you do a CKMM, because you have to be very clear that there is elevation of CKMM levels. And if it is there, then you label it as a statin myopathy. I would say that it is very, very less. You would understand that by just switching over or counseling the patient, this muscle pains goes off. You should also give it with vitamin D. As I said, vitamin D. So statin with vitamin D decreases the chances of muscle pain. You should rule out hypothyroidism, because again, that is one of the reasons for muscle pain secondary to statin. So these are the certain things that we should do whenever a patient comes with intense muscle pain and we suspect that it is because of statin. Statin has a very important role to play in primary and secondary prevention. So just by one complaint, sir, sharir bahut dukhe chhe, and you stop it, you are depriving the patient of many good effects of statin.
Kiran bhai is asking.
In that connection only, what is the role of this CoQ, coenzyme Q?
No, sir. Many of the trials initially in the era of 2013 to 2016 has highlighted coenzyme Q10 for statin-induced myopathy, for cardiomyopathies, but then the data was not very robust. So yes, it is in a gray zone. But we can also, as with vitamin D, we can give him a short trial of coenzyme Q10 along with statin to see if the muscle pain goes off. But the recommendations does not say so.
Jagdish bhai, you wanted to say something.
Yes, so I have encountered this scary drug interaction in 2 of my patients. There was significant rhabdomyolysis. The CKMM levels were in thousands. The patient had one of the patient had renal shutdown because of rhabdomyolysis and decrease in the creatinine clearance. The nephrologists were involved. He was put on dialysis, and fortunately, after 3 to 6 months, but his creatinine never returned to baseline. His creatinine still persists around 2.5 to 3. That was one of the case. The other case, luckily, we were able to go off with. So other than the 2 cases in my 15 years of career, I have not seen a very scary. But yeah, the patient, first patient was on dialysis for close to 6 months, and then he started pouring his own urine. The nephrologist put him up, got him off but his creatinine never recovered to baseline.
So those on statins should avoid macrolide. That is the message.
No, it was not. I'm not talking about macrolide antibiotic.
Because his question was
hydrostatin,
drug interaction.
Again,
his question was very specific. That have you ever encountered scary drug?
No, I would say that I have not encountered. But for hydrostatin leading to rhabdomyolysis, I had one such patient.
So not related.
Not with macrolide. I would not say. Yeah. So my take-home message would be not that you should not give macrolide antibiotics with statin, but I'll have to go through literature because I'm not aware of this. And if I find anything, I'll put it in the group.
Fine, that's good. Jagdish bhai, sorry, you were waiting for a long time. Yes.
You are muted, sir.
You have to unmute, sir. Yes.
Yeah. You did not mention about total cholesterol level, because usually people start with 200 total cholesterol as a normal, and anything above that, they start treatment.
Yeah, so basically none of the guidelines mention total cholesterol. The target, when you talk about target treatment, it is LDL-C, which is primary factor, and then non-HDL-C as a primary target. And we all know that the therapies targeted at reducing LDL-C, that is statin, would automatically take care of the total cholesterol.
And simvastatin is as good as other statins?
Simvastatin, when you compare dose to dose, the highest dose of simvastatin is only up to the moderate intensity. So yes, when you are when your patient falls in the moderate risk group and you want to give a moderate intensity statin, you have a choice of simvastatin. But your patient is falling into the high risk or the very high risk category, then you have to use a 80 milligram atorvastatin or a 40 milligram rosuvastatin, where simvastatin will not reach because 40 milligram simvastatin is equivalent to a 20 milligram atorvastatin.
Yeah.
There is a question about saroglitazar. What is your experience with
Yeah,
this?
so saroglitazar has a very so again this was not the topic for today's discussion. It is a topic in itself, and that is known as diabetic dyslipidemia. So again, diabetic dyslipidemia also has very high triglycerides. So saraglitazar is a good drug which is used in diabetic dyslipidemia when the triglyceride levels are very high, the HDL is low. It helps in both. It is a costly drug, yes, but it is not a first-line therapy. It is not a first-line therapy. So when you have already exhausted your options of the first-line therapy like statin, fenofibrates if required, ezetimibe, and still you are not able to achieve your goals, that is a triglyceride levels of less than 150, the HDL-C levels of more than 40, and the LDL-C levels of less than 100, 70 or 50, saroglitazar can be added for diabetic dyslipidemia.
Dr. Pradeep Seth has raised his hand. Yes, Dr. Pradeep bhai.
Yes, good morning, everybody. Dr. Neera, what I wanted to know was, is there any qualitative difference in the generic statins and the branded statins? There's a huge cost difference, almost
Yes,
10 times.
So, sir, again, this is an area of debate. We do not have, unfortunately, our government is not interested in classifying this, because there are two things. As you rightly said, that the innovator brand is almost 2 to 3 times costlier than the other brands. Recently, this has happened with a wonder molecule like sacubitril/valsartan. If you all know, Vymada by Novartis was priced as 80 rupees a tablet. Then it got off patent in January, and now around 70 to 80 Indian companies are manufacturing Vymada by different names at 17 rupees a tablet. So from 80, it has come down to 17. Whatever little knowledge that I have is from the industry people, and we know that the industry people are commercial guys, and therefore they may not be able to give us the accurate picture, but they definitely say with some scientific evidence that the isomers are sometimes different, the molecular ratio is sometimes different, but in our clinical practice we have seen that the effect on the lipid profile with the Indian or the non-innovator brand is also equivalently good. So if the government of India does something and does a scientific analysis of the molecules at their level and they come out with the data, then we will be able to surely say whether there's a difference or not. We cannot rely on the commercial medical representatives giving a data. But my goal would be, if with a local statin, the patient's LDL-C is less than 70, I'm happy.
Right.
Okay.
Oh, thank you.
Dr. Neera, we talked a lot about medications, but little bit about lifestyle, and especially there are a lot of questions regarding the use of oils in diet. So any comments on that? Which oils should be used? How frequently?
Yeah, so Lipid Association of India, if you see their site, they have 1.5 full page on oils. As you all know, olive is one of the best oils, but unfortunately, olive is more of a salad oil. People don't like the taste in cooking, and again, it's not a cooking oil. Then it comes down to the other good oils in the form of sunflower oil or rice bran or corn oil. What we should, even they say mustard oil is good, but again, Gujarati people do not use mustard oil. Normally, what my dietitian and me, I advise majority of the patient is the coconut oil and single filtered peanut oil should be avoided. Olive is the best, mustard is good. Then comes sunflower, and we know the ratio of MUFA and PUFA is important. Monounsaturated fatty acid, polyunsaturated fatty acid. all said and done, using the best oil, the quantity is most important.
Okay.
You cannot rest, because many of the patients start rest assured that sir pelo dil valu sapola layo chu એટલે હવે બહુ ચિંતા નહીં, પછી પૂરી ના તળાય એમાં. This is a common thing that we commonly tell our patients, that any oil is okay according to your culture and your habits since long, but restriction in the quantity is most important. Absolute no would be a coconut oil and single filtered peanut oil.
Okay.
Otherwise, if you the LAI on their website has a very good article on oils in Indian scenario. It's a 1.5-page article. It's really good.
Thank you. Thank you. So it was a very wonderful, elaborate talk on dyslipidemia. Thank you so much. And we end the session here and we meet next Saturday morning again. Thank you, Dr. Nirav.
Thank you, sir.